Thank you. All right, thank you, everyone. All right, so I'm Dr. Dupre. I'm with Our Lady Lake Physician Group. I'm a rheumatologist there, but I also wear several other hats. I'm currently their Chief Medical Information Officer, which means I'm helping them with all of the computers and putting in the new electronic record. I'm also an Associate Clinical Professor with LSU, so I do teach residents on a regular basis, so I kind of do scatter myself a little bit in different places. Like she said, I do have another engagement, so this is going to be a little bit of a rapid fire, and I'm going to try and leave some room for a couple of questions at the end, and we'll get those out as quickly as possible. But I did go over last time because there is a lot of information. What I'm trying to cover today is 3 large topics, so I'm really going to be touching the surface of those topics. I'm going to try and talk about what a rheumatologist is, but then osteoarthritis, rheumatoid arthritis, and a little bit about lupus on the side as well. So that's a lot of topics. These are things that it's taken, I had to go to a 2-year fellowship to talk about these mostly, and I'm about to give you in a 30-minute presentation as much as I can to give you a little bit of an idea of what they are, when you need to see a rheumatologist, when you don't. So first off, one of the things I'm going to talk about is what are the different types of arthritis. When you come to see a rheumatologist, we are like investigators. We're trying to figure out what's going on, what disease, how do we label it, because there's over 100 different types of arthritis out there. But there's 2 big main categories. There's inflammatory arthritis and non-inflammatory arthritis. Now, what does that mean when I say that? Inflammatory arthritis is when your immune system is involved and actually causes inflammation, swelling, redness, pain, and damage to the joint. Non-inflammatory arthritis occur because of degenerative causes or because of metabolic issues. So the joints are actually wearing down or being damaged by a metabolic issue and not your immune system. And so there's 2 very distinct types of arthritis. Osteoarthritis is one of our non-inflammatory arthritises. Rheumatoid arthritis and gout are inflammatory arthritises. And we'll talk a little bit more about rheumatoid and osteoarthritis today. I know there's going to be a few weird names up there. I'm going to kind of skip over those a bit because I don't go into detail on them. So what are some of the symptoms of arthritis? So there's a lot of things people feel from arthritis. The one most people tell me about is pain, of course. But the pain can be in different places. The pain can be in the joint, the pain can be in the muscle, even if the joint's the problem. The pain can be referred. So the pain can be in one place, but you feel it in another because the nerves get mixed up on where that pain is. So what we call arthralgia is joint pain. That's joint pain without inflammation. Myalgia, muscle pain. So all these weird doctor speak. It's just muscle pain. It's just joint pain. Then joints themselves can get stiffness, or you can get generally stiff. One thing we call gelling phenomenon. So if you sit down for a few minutes and then you get up and then that joint just doesn't want to straighten, but after about a minute it starts to feel better. We call that gelling phenomenon. The joint's kind of gelled because you sat down and it takes a little while to get it out. Morning stiffness, very similar. You've been inactive a little through the night, you wake up and all the joints or that one joint is stiff again. It takes a little while to get going. Oftentimes it'll take up to 30 minutes if you've got osteoarthritis. It can take hours if you have an inflammatory arthritis to get that better. Joint popping or clicking can occur when the tendons move over new bony processes that have occurred because of the arthritis. Joint laxity, bony enlargement, joint swelling, all of these are symptoms of arthritis, general symptoms of arthritis. Still doesn't tell me one way or the other what kind of arthritis yet. So, like I said, there are over 100 types, including osteoarthritis. DISH is diffuse idiopathic skeletal hyperostosis. It's one of those weird ones where it's a metabolic process where you put extra calcium on the joints and along the spine and it fuses both of those. Rheumatoid arthritis, gout, of course, is a crystal disease. Crystals form in the joint that activate the immune system and cause inflammation. Pseudogout, calcium crystals in the joints that cause inflammation. Osteonecrosis, which is loss of blood flow to the edge of the bone, which destroys the bone, can cause joint pain, damage, severe joint pain, really. Metabolic types of arthritis, lupus arthritis. So lupus can cause an inflammatory arthritis that looks like rheumatoid but has some very different features, which we'll talk about. So again, what is a rheumatologist? Where does a rheumatologist fit into this? How come a rheumatologist is needed when I have a primary care doctor or I have an orthopedist already? Well, rheumatology is a subspecialty of internal medicine. Internal medicine is adult medicine. It's general adult medicine. Usually we go through internal medicine training and then we go into rheumatology training specifically to talk about autoimmune diseases. So rheumatologists are doctors who deal with autoimmune diseases. Now, what is one of the most common symptoms of autoimmune disease? Arthritis. And so because of that, we become de facto arthritis doctors as well. We have to be very adept at looking at, treating, defining, and figuring out the different types of arthritis. But most of us would tell you we're here to treat autoimmune conditions in most cases. But we treat osteoarthritis and degenerative diseases as much as possible as well, because we have to evaluate them to make sure they're not part of immune diseases. So what do we usually do? We treat diseases medically. We don't do surgery. We don't do joint biopsies. We don't do arthroscopies. Those are things we leave for the orthopedist to do. We actually try to prolong the use of the joint, improve the symptoms so that we can put off surgery as long as possible in most patients. So a little bit different than orthopedists. So first today we're going to talk a little bit about osteoarthritis, which is one of the most common types of arthritis out there. Osteoarthritis occurs because of changes in the joint fluid that cause further breakdown of the cartilage and cause disrepair of the cartilage. So cartilage is that smooth covering on the edge of the bone between the joints that helps the joints move. It keeps the bone from rubbing on itself, because bone isn't really very smooth, and it doesn't really move well, rub well up against each other. So changes in the joint fluid can actually break your cartilage down and cause you to repair it abnormally. If you don't repair it correctly, that joint cartilage actually breaks down faster next time. Cartilage is a living tissue. It is continuously breaking down and building itself up depending on what you are doing and how your joints are structured and what pressure you're putting on your bones. It's a living tissue. It's not static. So it is constantly doing this. That is a normal living process. When it starts to get to a point where the cartilage is being laid down abnormally and repaired abnormally, it breaks down much faster and faster than the body can keep up with repairing it, and eventually you get osteoarthritis, breakdown of the cartilage. This can lead to pain, stiffness, swelling, limitation in range of motion, deformity, popping, clicking, all these symptoms we had talked about. It can affect any joint, especially for injured joints, but there are more joints that are affected more commonly than others. The knees especially. You know, this loves to hit the knees, the hips, the small joints of the fingers, predominantly the ones in the middle here and the ones at the ends of the fingers. It doesn't like the knuckles. Osteoarthritis does not like the knuckles. That's a difference than what we're going to see in a minute with rheumatoid. Rheumatoid loves the knuckles. So that's one way we can start to differentiate these diseases. The base of the thumb. Osteoarthritis loves to hit the base of the thumb. So there is a very weird joint at the bottom of your thumb. The base of the thumb joint allows you to move your thumb in all kinds of directions. Osteoarthritis loves to hit that joint, and when it does hit that joint, your thumb starts to drop down. When that happens, you lose that ability to move that thumb in all those different directions, and it impairs your grip strength. You can do some grip, but it's not the same as when you can actually open it and grab. And so that's one of the signs. This will get enlarged and the joint will drop down. We call it subluxation. We see that quite commonly. It is very difficult to handle and help. The neck itself especially, it loves the neck, it loves the lower back. And then this one interesting joint, the acromioclavicular joint. The acromioclavicular joint is a small joint on top of your shoulder. You press that hard part on the top of your shoulder. That's where your acromioclavicular joint is. That joint gets affected by osteoarthritis. That is a small joint, about the size of my knuckle or your knuckle, that actually bears all the weight in that arm. Your shoulder joint doesn't bear that weight. The shoulder joint, we don't see much osteoarthritis in it. If we see osteoarthritis in the shoulder joint, we're looking for some other reason for it, because usually there's a problem. This little bitty joint bears all that weight, gets the osteoarthritis, actually gets swollen and bony enlargement. The problem with this is when it gets large, it also gets large on the bottom side. Underneath that joint is one of the most important tendons for our shoulder, the one that lets us lift up. Okay? When that tendon continuously moves back and forth, it gets rubbed, it gets irritated, then it can get swollen, get inflamed, and cause problems. That's when we get pain in the shoulder joint, most typically from bursitis, because the tendon gets irritated and inflamed, or it gets torn, or it gets ruptured. That's the most commonly injured rotator cuff tendon, and that's the most common problem for our shoulders. We see it quite a bit. And it's not because of the shoulder joint or osteoarthritis in the shoulder joint, it's because of this little joint on top called the acromioclavicular joint. Orthopedists love to do surgeries where they actually open up the side of the joint, go in with a little scope, scrape the extra bone off the bottom to try and prevent that, and that works effectively for some people. So that's one of the things you'll see in osteoarthritis, is that wear and tear of that joint is actually a pretty big cause of shoulder problems. 21 million people in the United States have osteoarthritis. We like to say about 60 to 70% of people over age 65, if we took an x-ray of them, we'd see osteoarthritis. but not everybody's banging down my door. Why is that? Not everybody hurts from their osteoarthritis. You get pain from osteoarthritis for different reasons. Sometimes the bone itself can rub on bone. Bone can be very sensitive, and the nerves in the bone can cause some pain. The other reason, sometimes you get a little inflammation inside of there that causes swelling or irritation of the synovial lining. That can cause pain. But osteoarthritis itself is not a primary inflammatory disease. The inflammation comes secondary from the damage and the destruction that has occurred already. Those people tend to hurt. One of the things we do is try and treat with medicines that decrease the inflammation. Doesn't stop the disease, but helps the symptoms. Only for those people who have those problems that actually cause the pain from the inflammation. There are other reasons to have pain. Not always do those medicines work because of that. So again, what typically happens in osteoarthritis? The cartilage itself, like I said, begins to repair itself abnormally. Abnormal cartilage doesn't pull and stretch and then retain its flexibility as well as normal cartilage. It loses what we call elasticity, its ability to retain its shape after it's been stretched or pulled. So when we lose that, we actually damage the cartilage much more easily. As the cartilage gets damaged much more easily, we have a hard time keeping up with that repair. When it breaks down, the underlying bone thickens. As the bone thickens in response, you start to get more pain. As it thickens in response, it also grows extra parts on the edges of the bone, so it makes the bone larger, makes the joint larger. What is your body trying to do? When you lose that cartilage, you start to lose some of the stuff that filled up the space in between the joints. The joint gets lax, gets loose. Your body is trying to stabilize that joint by increasing the size of the bone and the thickness of the bone to make up for the loss of the cartilage. The synovium itself, so the lining outside of, on the edges of the joint that help provide all the nutrients and the fluid inside the joint, gets inflamed. The reason it gets inflamed is for several reasons. One, because of the abnormal movement can actually rub it and irritate it and catch it. But the other piece is the cartilage itself can actually flick off, and little pieces of the cartilage can get caught in the recesses in the sides and actually irritate the synovium as well and cause inflammation and swelling. All of that can cause pain in osteoarthritis. Even though the primary issue is not inflammation, the primary issue is the wear and tear, the damage, the degeneration. Synovial fluid itself, when you get damage to the synovium, the fluid itself actually gets dilute and becomes less effective. This synovial fluid is there to help maintain the joint and help to make the bones rub much more easily across each other, slide and glide across each other. When you dilute it, it loses those properties. And so, again, you can damage the cartilage much more easily because you no longer have that oil between the joint, between the bones. And then the synovial fluid itself also becomes less effective in providing nutrients for the cartilage. The cartilage does not have blood vessels going to it. The cartilage relies completely on the joint fluid to provide all of its nutrients. When you lose those nutrients or they become dilute, the cartilage becomes unhealthy as well. All of this is a continuous vicious cycle, destroying and damaging the cartilage and increasing the size of the bone and causing joint destruction. That is osteoarthritis. Here is a picture of a patient who has bony enlargement in the fingers. This is osteoarthritis. We call these Heberdine's nodes. Look here, bony enlargement again. If we were to press on these, they'd be bony. They wouldn't be soft. And so these right here are called Bouchard's nodes. These are very typical of osteoarthritis. Notice the knuckles. Is there any enlargement there? They look pretty normal. So osteoarthritis typically does not like the knuckles. Unless you have injured it in the past or broken a finger, usually it doesn't affect those joints. Here we have a specimen where someone actually cut a knee, opened it up. This is the patella, so that's the kneecap that's flipped down. So we're seeing the actual edge of the bone. On the edge is the cartilage, so all of this white area here, excuse me one second, all this white area here is cartilage. What is this? It's denuded cartilage. We lost the cartilage. The cartilage is gone. It got damaged. That's osteoarthritis. That's what it looks like when we open a joint up. Here are osteophytes that are caused by another disease that is similar, a degenerative disease called diffuse idiopathic hyperostosis. But this is extra bony growth, which would be similar to osteophytes. If we look at x-rays, what do we see on x-rays? So many of your doctors will look at these themselves and see, here, this would be a normal joint. So we got a little bit of joint space and we got very defined margins on the bone. Up here, do we see that? No, we have no space left. There's no edges to the bones. They're supposed to be. That's two different bones. What happened here is those bones actually fused together to stabilize that joint. There's no more cartilage there at all. That is a Heberdine's node. This is the tip of the finger. And so that's osteoarthritis there. Here's a closer picture. If you notice here, this is a progressive picture. So this is a little bit of joint space left in between these two bones, less definition between them. And you see there's these little spikes starting to form on the edges. That's extra bony growth. When you get here, these have actually fused together, and that extra bony growth is a little bit more knotty. Those are Heberden's nodes out on the side. That's osteoarthritis. What do we see with it? Again, joint pain, stiffness in the morning for less than 30 minutes. Gelling phenomenon is very common with osteoarthritis. Lasts for usually 2 to 3 minutes. Pain worsens with increased activity. So this is the arthritis that when you get up, you start getting about, you go to the mall, you know that you can only make it to that one store and back before you won't be able to get home without any pain. That's osteoarthritis, okay? Because the more you do, the more it hurts. Typically, when you start to do more, typically people generally just feel worse in the evenings with osteoarthritis. Okay? They feel better in the morning after they kind of get moving after that 20, 30 minutes, but in the evening they feel worse, more pain. You can get weakness because it hurts more, you end up using those muscles less. And then you weaken those muscles. When you weaken those muscles, guess what? The joints become abnormal as well. As the joint moves abnormally, you damage the cartilage more, you worsen the arthritis. So even though it hurts more, the exercise that you can get is actually good for the arthritis by strengthening your muscles and improving your joint laxity and decreasing the damage that occurs to the cartilage. You can get swelling of the joint from inflammation, which is secondary. You can also get bony enlargement and decreased motion of the joint because of bony enlargement or other reasons, fusion included. What causes it? We don't completely understand it. I'll be saying that a lot about the diseases that we treat as rheumatologists. I like to tell people rheumatologists are physicians who work within uncertainty at all times because many of our diseases are incompletely understood. Osteoarthritis is actually one of those. We know there are genetic predispositions to osteoarthritis. We know that these genes affect some of the proteins that build up our cartilage, break down that cartilage, but we still don't know if that is the whole story, and we don't think that is the whole story. So again, heredity. Osteoarthritis is highly heritable. Usually goes down the mother's line. So yes, you can blame your mother. Okay? Sometimes it comes down the father's side, but usually it goes down the mother's side. And very often you can get symptoms from people that their mother had it and their grandmother on their mother's side all had it. Sometimes you can't because the people who had it didn't hurt and never complained, but had changes. Had we done x-rays on them, yeah, they would have had changes. But again, a large amount of the population has this, so it's very common for us to see it either way. Let's see. Some people are born with joints that don't fit incorrectly, and they're at an increased risk for osteoarthritis as well. Increased laxity or double jointedness can also increase your risk for developing osteoarthritis in the future. There is a syndrome called benign hypermobility joint syndrome where all of the joints are rather lax, and you can do some interesting things with your joints. Those people are more prone to actually getting joint pain outside of osteoarthritis, and then they're more prone to getting osteoarthritis. We don't know that one causes the other, we just know that they're more at risk. What are other risk factors out there? What are the main risk factors? What are the things we see that if I look at you, you're more likely to get symptoms from your osteoarthritis or get osteoarthritis? Number one is obesity. So, increased weight on the joints worsens the damage to the cartilage. Either way. I mean, that's actually pretty simple. Your knees feel twice your weight above them. Your ankles feel 5 times your weight above them. That first toe, when you step off of it, feels 20 times your weight all the way above it. And so those joints feel a lot of pressure. They have a lot to deal with on a day-to-day basis. If we can decrease that amount of pressure, we can decrease the damage to the cartilage. That makes some sense. Muscle weakness. If your muscles are weak and they are not toned, there is going to be an increased laxity in those joints. You're going to damage cartilage more often. And so you can actually worsen osteoarthritis and increase the progression of your osteoarthritis. Injury. If you specifically injure a joint, that old high school football thing's acting up again, yes, that increases the progression of your osteoarthritis. You can get osteoarthritis faster in a single joint if you have injured it in the past. Aging, of course, we see an increased incidence with age because what? This is a degenerative disease. The longer we live, the more chance we have to damage our cartilage. The more abnormalities we have laid down in the cartilage, the more we will damage it over time. And so it is common for us to see it presenting after age 65 with symptoms. We see it more commonly then. Can it be prevented? Some people believe that the symptoms of osteoarthritis can be prevented. If you've got the genetic predisposition and you have the disease going on, most of the time you have it, but you may not need to ever feel it. You can prevent some of these symptoms. Weight control, staying active with low impact exercise, avoiding significant injuries to the joints. Now, there are also some studies out there that say some of the treatments we've been using lately, like the joint replacement fluids that we inject into the joints, may help, but it's hard to tell in those studies. When we do those studies, how do we measure osteoarthritis? We don't have a great way to measure osteoarthritis. If we look at x-rays, we can tell how much joint space there is in the knee and see how much cartilage someone has and see if that cartilage gets thinner. But if I take the x-ray with my knee straight out, that's different than if I bend it slightly or if I bend it all the way. There are different thicknesses of cartilage along the joint. And so that actually messes up our studies too. And it's not very consistent across the board. So we don't have great studies to say we can prevent the damage of that cartilage with this medicine. There are suggestions of it, but none of those studies are really solid. So am I stopping the disease? What is the treatment aimed at? We're going to talk about that in a second. How is it diagnosed? Typically, when you see a rheumatologist, we spend a lot of time talking to you. We try and find out and define the disease based off of what we hear from you and your symptoms. Then we do an exam. By the time we have talked to you, we have a short list of what we think is going on. By the time we do the exam, we should have a good idea of what's happening to you. Then x-rays, labs are there to help support that idea or to completely prove me wrong. Sometimes that happens. So when we do that, the other thing that blood tests are also helpful for, a lot of times you'll see us do blood tests, is to make sure that it's safe for us to treat you with some of the things we want to treat you with. So sometimes not all of the blood tests we're doing are trying to help you or help us figure out what's going on with you. A lot of times they're there to help us prevent us from hurting you in some way. So how is it treated or managed? Treatment is predominantly aimed at symptom relief. I do not have a medicine that will stop that osteoarthritis from doing what it's going to do. As I said, our studies aren't very solid on some of the medicines that we think may decrease the progression, but we do not have a good medicine study telling us this medicine is the one you use. It will stop the disease. No, we don't have that. We try and help you decrease pain and stiffness, increase your mobility, and increase the ability to perform your daily activities. That treatment could include all the way up to having a complete joint replacement. We don't do those ourselves. That's what we rely on the orthopedists for. They're our good friends. So when it comes to that point, that's what we have them do. Typically, as a rheumatologist, though, we try and manage medically up until that point. So physical and occupational therapy. So remember, exercise, low impact. These actually help increase your range of motion of your joints and can actually teach you exercises to continue to improve your muscle tone. Stretching exercises help prevent some of that decreased flexibility and decreased range of motion as well, and joint stiffness. So the more you stretch, the less stiffness you'll get. Aerobic exercise actually reduces pain. Exercise actually releases dopamine in the brain. What's dopamine? Dopamine is that chemical that makes you feel good. When you exercise, you can feel good. It decreases pain and symptoms just from doing it, not even from the other health benefits that come along with exercise, not even from just improving your muscle tone. It actually just makes you feel better when you do it. Initially, it feels a little worse, but once you get used to it, it actually feels really good. Weight control is one of the big ones. Remember, I said obesity is the #1 risk factor we see for developing symptoms of osteoarthritis. So if we can control weight, we can control some of those symptoms and decrease those symptoms over time. After all of that, notice I said after all of that, then we can talk about medicines to try and help symptoms. Now, in reality, if you come to my office many times, we're trying to do things concurrently. Medicines to help you improve your ability to do the exercise as well, decrease your symptoms so that hopefully you can manage and get off of the medicines in the future is what we hope. That doesn't always happen. So medications, nutritional supplements, glucosamine sulfate has been proven to help 60% of people. How often do people have a response to a sugar pill? 40% of the time. That's a normal placebo response. You feel better 40% of the time with a sugar pill. So 60% is not a huge difference for sulfate, glucosamine sulfate, but it is minimal. And that's only a couple of studies. There are conflicting studies out there. Analgesics, Tylenol. Tylenol helps reduce pain, doesn't stop any of the inflammation. Anti-inflammatory medicines. They help reduce the pain, and they're usually the cornerstone of treatment. So Advil, Aleve, ibuprofen, BC, Goodies, Standback, those medicines, they have their side effects. You have to be careful with them, but those are usually the cornerstone of treatment for osteoarthritis. Topical analgesics. Salicylates are basically anti-inflammatories that we just rub on the joint. They still get into the joint and they still do help. Capsaicin. Anybody know what capsaicin is? Hot peppers, right. So this is the chemical in hot peppers that make them hot. The scale for measuring how hot a pepper is based off of how much capsaicin is in there. How in the world is that going to help me by rubbing that on my joint? Anybody have an idea? No. After the burning is done. And after my eye stops burning because I rubbed it. After the burning is done, you've actually eliminated your nerve's ability to send pain signals for a little while because it's gotten rid of all of the chemicals that were stored inside the nerve to send those pain signals. You've depleted it. And so the nerve can't send pain signals for about 30-40 minutes. That's how this works. Skin irritants do the same thing. Topical anesthetics actually help prevent the signaling from that nerve of pain altogether. And so these topical things can actually help some people relieve their symptoms and keep them moving. Injectable steroids. Steroids do what? Reduce inflammation, make it feel good. They have side effects. They do not stop the disease. They only temporize. Hyaluronic acid replacements. These are joint fluid replacements we actually inject into the knee as well. Hyaluronic acid, it stays in your joints maybe 2-3 weeks. The result, the effect, can last 6 months to a year when it's effective. Now, so it's in your joint for 2 weeks, yet it lasts 6 months or a year. It's not because we're relubricating the joint. Hyaluronic acid is actually an anti-inflammatory, and so it does work by that method as well. So it's not the same when you think, oh, I'm putting more fluid in my joint, that's helping it stay. No, that's not it. It's actually an anti-inflammatory. Acupuncture. So we have done studies on acupuncture. Acupuncture has been proven to reduce pain and stiffness and range of motion in people who have knee osteoarthritis. Now, when they did the study, how did they do that study? They put people on a sugar pill. They put people and gave them acupuncture. They had a professional acupuncturist give them acupuncture. And then they did what's called sham needling. Anybody know what sham needling is? We just took somebody off the street who knew nothing about acupuncture. We let them put needles in you. That's sham needling. So the people who took the sugar pill got how much relief? 40%. That's a placebo response. People who got acupuncture got 60-70% relief. People who got sham needling got 60-70% relief as well. So it's a function of putting the needles in. Now, that is very similar to when we do the capsation. You decrease how much your nerves can actually send that pain signal. So, but acupuncture does work. And I do have a few acupuncturists in town that I actually send people to that actually help. For some people, that's actually a very good treatment, especially if you're not scared to death of needles. Surgery. There are multiple types of surgery out there. It's not all just total knee replacement. There is arthroscopy, where they put small scopes in the knee and try and scrape out the abnormal parts. There's osteotomy, where they actually try and create holes in the cartilage to try and force it to repair itself. There is cartilage transplants. They can take cartilage from the back of the knee and push it to the front of the knee. There are also total joint replacements, of course, which is kind of the end of the line. Then there are some experimental treatments out there that are being tried, but none of them look too promising right now. I've actually probably got to update this slide about those. Now, we've talked a great deal about osteoarthritis, mostly because it's the most common and one most people see. The next two things I'm going to go through very rapidly because we've got about 4 minutes left on the clock. Okay? Rheumatoid arthritis and lupus. Two big topics we're going to try and go through real quick. Okay? Rheumatoid arthritis is an inflammatory arthritis. This type of arthritis is due to the immune system actually attacking your own joints. Your immune system, remember, this is the part that protects you from viruses, bacteria, cancers. Typically, when you've got a virus or a bacteria, your immune system flares up, destroys that virus, bacteria, and then shuts itself off. Unfortunately, with rheumatoid arthritis, your immune system has looked at your joints or looked at a part of your body and said, oh my God, that's a virus, that's a bacteria, and attacked it. Now, does that part of your body ever go away? No, it's part of you. It's normal. It's a normal tissue, and your immune system's attacking it. So the immune system does not shut itself off. And so this inflammation continues and progresses and goes on for years. People can develop symptoms immediately. They can wake up with multiple swollen joints, tender, painful, swelled, swollen, can't move, feels worse in the morning, feels better when they walk. That's rheumatoid arthritis. It can come on slowly. You can get one joint that gets red and swollen, stays for a while. Another joint gets red and swollen, stays for a while, until it progressively adds up to a bunch of joints. It can persist for years, affect many joints. Remember, osteoarthritis damages the cartilage and the surrounding bone. Rheumatoid damages the cartilage, the tendons, the ligaments, the bones. All of the structures of the joint get damaged from rheumatoid arthritis. A lot of people have it, 0.5 to 1% of the population in the United States. Native Americans have a much greater frequency. 5% Native Americans actually have rheumatoid arthritis. What causes it again? The immune system attacking the joints and other parts of the body. Rheumatoid arthritis is not just about the joints. The joints are the most common symptom, but it is a systemic immune disease. It affects the rest of the body. Rheumatoid arthritis is genetic in nature, but not everybody who inherits the genes gets the disease. So we inherit the ability to get rheumatoid arthritis, not rheumatoid arthritis itself. What happens is it takes something else to set it off. It takes a trigger. Something's got to set that immune system, that part of the immune system that has been active, turn it on. And when it turns on, then it doesn't stop. That trigger could be a virus, it could be a bacteria, it could be an infection, it could be anything that is somewhat will trigger your immune system. The reason we can't identify one is because there's so many triggers for different people. There is only one thing we have identified that definitely triggers rheumatoid arthritis. That's smoking. People who smoke are 9 times more likely to get rheumatoid arthritis than people who don't smoke. So one reason, don't smoke. The other reasons for arthritis and smoking. If you have arthritis, smoking actually causes flares of the rheumatoid arthritis. So every time you take a drag on the cigarette, you're more likely to get a flare of the rheumatoid arthritis. It also makes it harder to treat. It inactivates some of our medicines. It decreases blood flow to the joints when it decreases the activity of the medicines out there. It also impairs your ability to heal the damage from the rheumatoid arthritis, and it prevents the growth of new blood vessels. So you can't even grow new blood vessels to get out to those joints and repair that damage. Smoking is bad for arthritis. So that's going to be my little tenet on that. I didn't even mention any of the other things about it. So symptoms of rheumatoid arthritis, again, vary from person to person. It can start very suddenly, or it can start slowly and gradually. The joints typically are inflamed. When I say inflamed, they get red, they get swollen, they get tender. They also have morning stiffness that lasts for several hours, but gets better when they start moving. These people feel better when they move, they want to get out. It's just hard to get that first part of the day over with until they get better. They feel worse in the morning, better in the evenings, until they lay down and don't do anything, and then they start to feel worse. They do get damage in most places. Other symptoms include general symptoms of inflammation. Malaise, what is that? Yeah, that's our doctor speak for saying you just feel bad. You know that general feeling people say, I just don't feel good. That's malaise. Weight loss, decreased appetite, fatigue. These are general symptoms of systemic inflammation. So guess what? You can see that in an infection. You can see that in cancer. You can see that in rheumatoid arthritis. So it's also part of our job to differentiate between all these 3 things and then try and hone in on what the main problem is. You can also get, like I said, this is a systemic disease, other organ involvement. You can get inflammation in the lining of the lungs and the heart. You can get nodules in the lungs. You can get dryness of the eyes and mouth from inflammation of the glands that produce the saliva. This is called secondary Sjogren's. You can get vasculitis, where the blood vessels get inflamed and cause damage, and you get ulcerations and pitting and damage of the fingers and the skin. Here's a picture of someone with rheumatoid arthritis. You notice here there's a little bit more of a different type of swelling. It's not just large and bony. It's a little more what we call fusiform. If I were to press on this, it would be soft. I'd also get hit with the other hand, because this is very painful. Notice the other joints here aren't affected. It doesn't like the joints out at the tips of the fingers. It likes the ones in the middle and the knuckles. Remember, what did I say about osteoarthritis? It doesn't like the knuckles. It likes the middle and the tips. That's one way for us to help differentiate it. And so there's very different ways and little subtle clues that we use as rheumatologists to figure this out. This is advanced rheumatoid arthritis. I don't see this as much as I used to, and I'm glad for that. We have better medicines to treat rheumatoid arthritis today than most other diseases we treat. This is advanced to where these joints have actually been damaged so much that the bones in the front of the fingers have subluxed under the ones in the back. So they are now this way. Now, with rheumatoid arthritis, those bones fuse as well. So I can't push these out. I'd actually get hit with the other hand again if I tried to do that. But these people can try some grip, but they cannot open up that hand anymore. Here, these are swan neck deformities. This occurs because of damage to the tendons and the ligaments around the bone, around the joints. There are 2 hoods on your joints, ones that allow you to flex them and some that allow you to extend them. When they pop and flip up, you get too much pressure on one side of the joint and they create this. This is called swan neck deformity. This is arthritis mutilans. This is a very severe rheumatoid arthritis where the joints have been destroyed so much so that there's not much in between. It's all just fused bone. I have not seen a case of this in a long time in rheumatoid. Now, this happens more commonly in psoriatic arthritis. I've actually seen a couple of people with this. No more bone in the finger. It's a floppy finger. That happens with psoriatic arthritis. Rheumatoid nodules. So these are little bitty pockets of inflammation that occur usually on the extensor surfaces of the joints. The elbow is the most common place we see these. Rheumatoid arthritis affects the bone. So on this, excuse me. So here, this is a normal joint. Here we start to see something here starting to wear away. over here, full erosion. That's the very beginnings of rheumatoid arthritis. This is what we see on x-rays. When I take x-rays of your hands, if I see this, I'm a little late. I'm already a little behind the game. I like to try and prevent this. So x-rays aren't the best place for me to diagnose. If I'm diagnosing off of x-ray, I'm a little late. Okay? I like to see it earlier than that. This is that severe damage that we saw. Erosion, fusion of the bone, extra growth of the bone right there. Lung nodules right there. How's it diagnosed? History, exam, blood test, just like we talked about with osteoarthritis. X-rays help sometimes, but like I said, if I see it on x-ray, I'm a little late. How we treat it. Early treatment is essential. When we sit down and I start to talk to somebody and say, I'm going to treat your arthritis, here's what we're going to talk about. First off, I've got 3 goals. The first goal is trying to make you feel better. I'm going to try and get you moving, try and get that stiffness out, try and get that pain out as much as I can. Try and make you feel better. The next goal is to prevent long-term damage and disability. Okay? I'm looking at you. I may make you feel better, but I may have to change your medicines anyway because I'm looking out 5, 10 years down the line. I see something that's still going to make you deformed and disabled. The last goal is to try and not hurt you with the medicines I use. Okay? I use some very severe, serious medicines, and we have to monitor very closely because they can hurt and harm you. In many cases, they are safe as long as you are under the care of a rheumatologist and following up regularly. So those are the 3 goals I usually have for people. They don't always align together. So the things that I do may be at odds with how you're feeling sometimes, because that's how we actually look at things. There are 2 big groups of medications we use. Medicines for just symptomatic relief and medicines to try and stop the disease in its tracks. Those are called DMARDS, disease-modifying anti-rheumatic drugs. Fancy name for just drugs that stop the disease. Symptom relief, we use non-steroidal anti-inflammatory medicines again, Advil, Aleve, ibuprofen, some of the stronger ones. Analgesics, Tylenol, Tramadol, narcotics. All they do is stop the pain. They don't actually help with the symptoms. Corticosteroids, decrease inflammation, decrease swelling, decrease pain, have tons and tons and tons of side effects. So oftentimes we use them initially until the other medicines work and then stop them if we can. There are some studies out there that say that they might stop progression of the disease, but their side effects are not worth continuing when we have other medicines, so we don't use them that way anymore. Methotrexate is our mainstay of therapy. It is a medicine that we use to suppress the immune system, the bad parts of the immune system, help enhance the good parts of the immune system, hopefully stop the disease. It is the medicine we use the most. Plaquenil is another medicine, used to be used to treat malaria, actually good at stopping inflammation for mild disease. Sulfasalazine is an interesting medicine. It is a combination of an antibiotic and an anti-inflammatory medicine. Now, that's very interesting because which part do you think works? Which part do you think decreases the inflammation in rheumatoid arthritis when it does work? It's actually the antibiotic and not the anti-inflammatory. This medicine was created long ago when we thought rheumatoid arthritis was an active infection. And so we were trying to treat it with an antibiotic along with an anti-inflammatory medicine was combined to try and treat with both. Later on they found out that the anti-inflammatory medicine is released in the colon and not absorbed. And so it's effective in the colon but nowhere else. But it's the antibiotic portion that actually has an anti-inflammatory effect and has nothing to do with infection and actually helps. So it's still used in some cases, especially refractory cases when we need to add something on for just a little bit more oomph. Leflunomide, azathioprine, cyclosporin, all immunosuppressive medicines that we give by mouth. Here is a list of medicines that we actually give by injection or infusion. These are the medicines that actually stop the disease. These are now part of the mainstay along with methotrexate of treatment of the rheumatoid arthritis. This medicine can prevent those deformities that we saw earlier. There's a wide variety of them. This is typically the medicines that people get this aha moment, oh, this is the best I've ever felt in my life when we do use them. So there are several of them out there. I'm not going to go into any one in particular. Real quick, lupus. On one side we had rheumatoid arthritis, main symptoms, joint disease, joint damage, joint destruction. Lupus is a multi-system, multi-wide, multi-organ disease, affects all organs at any time. Usually though, when one person gets it, they get it a certain number of organs affected, and that's what they get whenever it flares again. They don't usually add new features. Lupus itself, like I said, affects a wide range of your organs. It's a systemic immune disease. What lupus probably really is multiple immune diseases that we don't have a handle on that we all group together and call lupus. Okay? And that's probably what lupus is. But lupus, every person who has lupus presents a little differently than the next person who has lupus. And we have to use very defined criteria to try and diagnose this. It is a typically relapsing remitting disease, which means you feel better for a while and then you relapse, and you feel better for a while and then you relapse. That's a typical course of the disease. Even with treatment, we try to decrease those relapses, decrease the severity of them, and prevent as much effects from that disease as possible. It's very diverse. Let's see, female predominance, 9-to-1. You'll see that a lot with immune diseases, that they are more female predominant. There's only a couple out them that are male predominant. What causes it? Again, the full pathogenesis is poorly understood. There are multiple causes and multiple parts of the immune system involved. I'm not going to go straight into that today. What are some of the symptoms? Again, general multi-organ symptoms, general inflammation, malaise, fatigue, tiredness, weight loss. What are some of the more specific symptoms that we actually try to use and find to help us diagnose it? Different types of rashes, malar rash, discoid lesions, photosensitive rashes, different organ involvements, arthritis, that's not as destructive as rheumatoid arthritis, nephritis, which is kidney disease, that is kidney inflammation, seizures, psychosis, anemia, lymphoma, thrombocytopenia, things that can put you in the hospital because of low blood counts. And then a few lab abnormalities we look at, one of them being the ANA. The ANA is what everybody calls the lupus test. Unfortunately, I hate that name for the ANA because it's not really the lupus test. ANA, when we get a positive ANA, about 80% of the time, it's not associated with anything that we treat. An ANA test is a marker of immune dysregulation. Doesn't mean you'll develop anything from it. Also, you can get positive ANAs from having thyroid disease and many other types of diseases as well. But when we get a positive ANA, we have to evaluate for these types of symptoms to see, do you have lupus? And we get a lot of positive ANA consults, and oftentimes we see there's another reason they had the ANA test and not actually lupus. But in order to have lupus, we usually have to say you have to have a positive ANA for us to tell you have lupus. Otherwise, we're hunting for something else in most cases. Here, we have a classic butterfly rash. So this is a red raised rash along the face in a butterfly pattern. Part of the reason it makes a butterfly pattern is because this rash always spares the nasolabial folds, this area here. Rosacea, the other rash this gets confused with quite often, does not spare the nasolabial folds. There's another rash that this gets confused with. It's called photodermatitis that affects the face. It's often not due to lupus, but looks very similar to this and comes with sun exposure. Now, unfortunately, lupus actually, one of the main symptoms is photosensitivity as well. This is a photosensitive rash from lupus. Someone went out in the sun for 5 minutes, developed this rash, it ulcerated, got painful, red, swollen. Very active, mean looking. This is discoid lupus. So these are inflammatory lesions in the skin. The center is scarred. All of these hyperpigmented outer edges are active. Those are the parts that are inflamed. The scalp, he's bald, he's going to be bald. After it scars off, you can't grow hair again. So when you get discoid lesions in the scalp, you don't regrow the hair. Here, this arthritis, doesn't this look similar to some pictures we saw earlier? The difference between this and rheumatoid, I can straighten these fingers out. Rheumatoid, you can't. And some of these people still maintain an active grip, but their fingers, when they relax them, they look like this. Excuse me. Symptoms of lupus can be exacerbated in many ways. One of them is through sun exposure, just plain sun exposure. Things that cause the immune system to act up or increase the work of the immune system can do this. Emotional stress, infection, certain drugs, surgeries, hormonal changes. Sun exposure, when you go out in the sun for a few minutes, you do get a little sun damage. What cleans up that damage? Your immune system. So your immune system has to be a little bit extra active. That can actually trigger some of this. How do we treat it? Again, symptomatic treatment, NSAIDs, corticosteroids. We suppress the immune system with different medicines. Azathioprine, Celsep, Dapsone, Plaquenil, methotrexate, cyclosporin, all kinds of different immunosuppressant medicines. Leflunomide, thalidomide. One of the other ones, we have one infusional medicine. It's a new medicine. It's called Benlysta. Out of all those, 3 of them have been approved for treatment in lupus. Steroids, which I told you I don't like that much because of all the side effects, so we don't use them chronically. Plaquenil, which has been shown to decrease death rates but doesn't control the disease altogether because it's a mild medicine. And then Benlysta. So those are only 3 approved medicines for lupus, yet we've used all these other medicines for years to try and treat lupus and have multiple studies on them. So that was a very quick overview of those 3 diseases, trying to fit a lot in a short amount of time. If you're looking for more information, of course, the Arthritis Foundation or the American College of Rheumatology, and you have flyers that have actually our website, and this is our office number if you need to make an appointment.